So I'm going to introduce our next speaker. So this is Dr. Elaine Husney, and she is currently the Vice Chair and Director of the Arthritis and Musculoskeletal Disease Center at the Cleveland Clinic. She has a particular interest in the areas of spondyloarthritis, and I learned today that she actually was the founder of the clinic that Dr. Merola and I worked at the Brigham. So, it's really interesting to get to meet different colleagues from different times. So without further ado, she's going to talk to us about psoriatic arthritis.
Home stretch on the second day. I'm so impressed that people are still here. So I'm second to last talk today. It's great to see everyone. So we're going to turn our attention to psoriatic arthritis. I know just being at the meeting so far, there's been a lot around this topic. It's funny when I've always been interested in psoriatic arthritis, and when I used to go to the ACR meeting, which is our national meeting, we used to have like these little booths on the corner, and now psoriatic arthritis, spondyloarthritis is sort of as big as rheumatoid arthritis in terms of the treatments that we have. So it's a really exciting time to be talking about this disease. So here are some of my disclosures. Learning objectives that you see here. So I'll go over a little bit about the pathogenesis, which I know will be a little bit of a repeat, some of the obstacles we face, and sort of the current treatment barriers that we have. So this is our classic for those of us who train rheumatology fellows. This is sort of the interrelated diseases that are all in the spondyloarthritis family. And because they all share some immune and genetic markers together, they're sort of grouped as a family of diseases. The most common is the ankylosing spondylitis, who as has been going under sort of a change. I know we're not talking about that today, but it's important to remind us that these, as this pathogenesis is being better understood, we're changing the way that we're talking about naming these diseases as well. So this is psoriatic arthritis. I know Dr. Rosenbaum had some really cool pictures, so I thought I'd add some pictures too. So the point of this is to remind us that it's not just skin and joints. So there's a lot of also extra articular, extracutaneous manifestations as well that I will go over. So here is sort of how I think about it. I think what is different from rheumatoid arthritis is that there are many different patterns, and you can fall in and out of some of these patterns. So you can have clinical patterns with are either peripheral or distal involvement, oligoarticular. You can also have 5 different domains, and I'll talk about that. That becomes important when we look at our treatment algorithms. And then there's also 5 different presentations of skin disease that can occur as well. So as you can imagine, there's a myriad of ways that your patients can present. So how do you develop treatment algorithms? How do you think about your patient moving forward? So some of the unmet needs or challenges as I was thinking about doing this talk, I was like, what do people want to sort of hear about? What can you not just get from doing a PubMed search and on all these treatments that we have available. So what I found interesting as a whole is that despite all these extra treatments that we have for psoriatic arthritis, I would say that the skin is really beating the joints. I mean, you are seeing skin disease clearance like we've never seen before. But yet the joints, whether it be an older therapy that we know of an anti-TNF, or one of the newer therapies, we're really still talking about the same joint coverage. There isn't really in our rheumatology world, an ACR 100 that we're seeing like we are with PASE 100s. We also know that despite having sort of a precursor for psoriatic arthritis, right, most patients have psoriasis first, and about a third of the psoriasis patients go on. We still don't really know who's going to go on to psoriatic arthritis. And despite all these numerous therapies, the management and treatment algorithms are evolving, and I'm going to go over some of the treatment guidelines as well. So what makes psoriatic arthritis different from rheumatoid arthritis? The first and foremost is we do a lot of x-rays as rheumatologists, and what do we look for? We look for erosions, we look for things that are poor prognostic factors. But what's interesting in the spondyloarthritis is not only do we see erosions, right, we also see bony proliferation and where bone is laying down. So in ankylosing spondylitis, we see syndesmophytes, and in psoriatic arthritis, we can see bony proliferation. So why are we having 2 different things that are sort of ongoing in psoriatic arthritis? So looking at pathogenesis, I always like to see these cartoons, and they're always colorful and a little bit difficult to kind of read sometimes. So, but the important thing is here is that this is a highly, highly regulated network of immune cells that work in sync. And when we think it can be so easy as when we see one upregulated and we try to block it, it doesn't always treat all the manifestations of the diseases because these immune cells are working together. So here's just an example of looking at the joints and looking at the skin. They share a lot of the same mechanisms, but really it's a dysregulation where something is getting triggered and really tips the balance to a pro-inflammatory cytokine pattern. And many of our treatments are aimed at blocking. And so I challenge you to think, is really blocking the way we should go, or is rebalancing the way we should go? And although we may not have a treatment that rebalances, it's something that we really are probably our goal, because just simply blocking sometimes does not treat all the manifestations. So I love this cartoon. I'm going to spend a little time on it if I can figure out how to use the pointer. But for those that are not rheumatologists, you might not be as familiar with the enthesitis, but that's where it all starts. And this is what makes it really different. Because in rheumatoid arthritis, the bulk of what's happening, I always think of, is that it's starting from the inside. It's starting from the synovium inside the joint, while the spondylarthritis is really starting a little bit outside the joint or in the enthesitis. So the enthesitis is this area where the tendons, ligaments meet the bone. And in this area is where we see an upregulation of IL-23. So for those who are looking on this side, so IL-23 here. Now, what triggers the increase in IL-23, which is a survival mechanism for Th17, we don't really know. So these are these little boxes that you see here. So it could be maybe something to do with the gut microbiome, and we've talked a lot about that during this conference. Maybe there's changes or dysregulation in the gut microbiome that triggers IL-23. Maybe it's a genetic factor, an unfolding protein. Maybe it's biomechanical stress. So the areas that we see enthesitis being affected are usually areas that undergo a lot of physical stress. And so this is an area of big research interest, trying to figure out what triggers the production of or overexpression of IL-23, which then allows you, as you can see in this nice cartoon, I just love this article by Sherlock. So what it does is then it goes on to producing IL-22 and IL-17, and then further on the cytokines that involve the changes that we pick up on x-rays, that we pick up on exams, so the ankylosing, the bony fusions that we see. So enthesitis, I'm just going to go over some of the clinical manifestations just to remind us. So this is what we see clinically from what I just showed you, where the inflammation of the tendon meets the bone. Achilles tendon is one of the most common, easiest places for us to see, but you can get it in the elbows, you can get it on the tops of your knees as well. Dactylitis, this we don't see as often, but when we see it, it's great because then we know, you kind of fall in the spondyloarthritis family. So this is that typical sausage toe, sausage fingers that's easy to spot, but not always there. But when it's there, it's very helpful. I know you've gotten a lot of derms, and my derms colleagues have talked about different presentations of skin disease. What I think is interesting with skin disease is that we're learning that perhaps some of the nail changes that we see could be a risk factor for psoriatic arthritis. So this is a big area where we're doing ultrasound work and really trying to understand the mechanisms. How interesting it is that where the nail is affected is usually where the joints are affected. And we also know that skin usually precedes joint development. So here's that Casper criteria. So here, this is really a classification criteria, so not so much to diagnose, but in our clinical trials, we really try hard to get the same type of patients in. So how do we do that? So what we do is we usually list inclusion criteria. So here you have to start with somebody with inflammatory arthritis, and then you have to get some points. And how do you get the points? So if you get greater than 3 points, then you make the classification criteria for psoriatic arthritis. So here, as you can see, is the list of things to get points. So you actually don't even have to have active psoriasis. You can have a family history or a personal history of psoriasis. Nail dystrophy is on there, a negative rheumatoid factor, dactylitis is on there, as well as radiographic changes. So this is an area of interest of mine as I was doing the Derm Rheum clinic, is that if there's 300 million Americans and about 3%, and I know this changes, of the U.S. population that has psoriasis, there's this really important window. It used to be 10 years, but now I see studies showing that there's a shorter time period between when the skin develops and when the joint manifestations develop. And this is really a great window for us to think about how we can get these patients diagnosed sooner. So one of the things I've, in doing my Derm Rheum clinic with Abrar Qureshi, we noticed that many patients are seen by the derms. And dermatology doesn't necessarily order x-rays. They don't ask about inflammatory back pain. They may or may not ask about morning stiffness. I think we're all getting better, especially with these IAS Summit, where we're meeting people from different disciplines. But on a whole, dermatologists are not trained the same way that rheumatologists are trained. So Abrar and I thought, well, you know, it might be nice to maybe survey these patients that are coming into the dermatologist, not overall in primary care, and maybe ask them some questions. So this is a patient-directed questionnaire that I did as a fellow. And basically, it only takes a couple minutes to do, and if you get a certain cutoff, a certain number of scores, there are 15 questions that look at symptoms and function. And there's lots of screening questionnaires that are out now since this came out. But it's a way to maybe help the patient and the dermatologist get to rheumatology sooner. So we talked a little bit about extra articular and extra cutaneous manifestations. So here's just to remind us, I don't have time to go over all the comorbidities, but it's always good. I know you can't do this all in one visit, but you try, as you're knowing your patients over time, you really, you know, this month, next month, you try to go over some of these comorbidities. You just try to keep it alert. You try to educate the patient so they come to you also when they start having any GI symptoms or things like that. I will go over some comorbidities that I think is important. Depression, for example, I think is something that we all know that can influence the way that the patient responds to treatment and how they're doing in their life. So there's a high prevalence of depression and anxiety. There are certain therapies, such as apremilast and brodalumab, that are associated with some worsening of mental health issues. So those are something you might want to have a conversation with your patient. You might choose different therapies depending on how their mental health is. Obesity, we talked a lot about obesity as being a pro-inflammatory sort of environment. But what I think is really interesting here in this study, it looked at people that were the odds of achieving something called MDA. So MDA is minimal disease activity. So what are the chances of somebody reaching a low disease activity state if they're overweight or if they're obese? And what this study found is that as your BMI is elevated, you actually don't respond to medication as well as you could have. And so that has a lot of implications. We see a lot of patients in our office that are overweight, and it's difficult because you have less time now in the clinic, but yet you're gaining more understanding of comorbidities. And where's that line of trying to help your patient? But I think studies like this, which really tells us that therapy is actually different in patients that are overweight, I think becomes a much more crucial conversation that you can have with your patient. Cardiovascular, I know that we've been going over a lot of cardiovascular studies. Psoriatic arthritis is no different than many of the other immune-mediated diseases. There's an increased risk of cardiovascular disease. These are some of the studies. Don't have time to go over each of them, but just to remind us that it's also seen in psoriatic arthritis. This is a study I did a couple years ago thinking about whether or not having psoriasis alone or having psoriatic arthritis that affects both the skin and the joints, is somebody with psoriatic arthritis worse than somebody with psoriasis. So here we looked at something called IMT, so that's intima media thickness. It's between the yellow line and the pink line. The yellow line, the pink line you can see here is a little bit wider. Anything greater than 1 millimeter is considered positive in ultrasound, and this is sort of an indirect way to look for atherosclerosis or early atherosclerosis. So what this is showing us here is that there is not only plaque, but increased intermedial thickness in patients with psoriatic arthritis compared to psoriasis. So there may be some differences amongst the diseases that we might have to think about, and there's lots of other newer studies also looking at the differences between these folks as well. So screening considerations, so you saw the chart with all the different extraarticular and extracutaneous manifestations. So this is just a little chart graph just to remind us what do we do about screening. We are sort of all over the map. Our patients aren't probably bucketed as well as sort of somebody with diabetes, where the AHA have certain guidelines. So we know that there's a risk, but whether or not there's actually guidelines from the American Heart Association to help us with cardiovascular risk may not exactly be there, but it's important to think about these things. And these are some of the ways that we can screen for some of these comorbidities. So the last half of the talk, I'm going to focus on mechanism and treatment. So this is a little graph that I did, and I don't expect people to sort of memorize it, but there is psoriasis, psoriatic arthritis, and ankylosing spondylitis. And I think what I'm trying to point out here is look at where all the red dots are, right? So it's kind of more towards the ankylosing spondylitis. So despite all these new treatments and our understanding of the IL-17, the IL-23 and Th17 axis pathway, there's still a lot that we have to do in ankylosing spondylitis. As you can see, a lot of the treatments that you would think that work in this family of diseases don't move forward in the ankylosing spondylitis. And a lot of it that is good in psoriasis also may not be good in psoriatic arthritis, which I think is really interesting to note. So this is just sort of a color schematic landscape that I wanted to do. So what's new in TNF? I'm just going to go over some of these classes. So TNF therapy, so the green is ACR. So ACR is the way that we measure joints, and I'm going to superimpose it onto PASE, which is the skin. And as you can see, the skin sort of in blue kind of beats a lot of what you see in green, showing that TNFs can clear skin a little bit better than it can clear joints. So other things that are new, we have ARIA Symphony, which now has an IV form approved for psoriatic arthritis. And then we have Certolizumab Pegol, Cimzia, which has some new studies in maternal fetal health. So just to remind us some of the, I know that we're really comfortable with anti-TNF therapy, but as we evolve, there are some new indications. So here are some of the studies that have come out, given that Certolizumab Pegol has a pegylated anti-TNF. And in trials, we've seen that it does not cross the maternal-fetal transfer, and sometimes can be safer in women that are thinking of family planning. So this is the crib and the cradle study that you guys can review. We had a morning session on this as well, but it's really nice to know that we have some differences amongst the TNFs. Methotrexate. So methotrexate is something we are very, very comfortable with in psoriatic arthritis. Very comfortable in rheumatoid arthritis, But in psoriatic arthritis, we're not as clear whether or not we should be using this in combination with our TNF therapies or not. So what do you guys do with methotrexate? Do you tend to keep it on, raise of hands, when you're treating? Or do you kind of pull it off and start when you're ready to start a next mechanism of action like a TNF? So I'm going to talk about the SEAM trial. But before that, we want to think about why we might want to be keeping methotrexate on board. So if you look at sort of whether or not studies that support using methotrexate, studies that support not to use, it's sort of overall, I would say that most people still keep it on board. Because maybe it's what we're used to, maybe it's an immunogenicity issue. There's lots of reasons why somebody might keep methotrexate on board. So here's a study looking at biologic survival with the effect of methotrexate, specifically with psoriatic arthritis. So what you can see here is that it may matter for some TNF more than others. So this is a graph looking at combination therapy versus monotherapy of the, so in things like infliximab, if you look at the middle chart, clearly you can see that methotrexate makes a difference with some of the TNF. And then some of the other ones, it's not so clear. So this is the SEAM trial. So this led to the SEAM trial, which is looking at etanercept and methotrexate in either monotherapy or combination. So this is sort of a long-awaited trial because we're trying to answer the question of what should I do with my methotrexate. And interestingly enough, it looks like monotherapy is doing well. So we actually don't see an augmented benefit with methotrexate with the SEAM trial. So this is sort of a long-awaited trying to figure out what to do with this in terms of a randomized control phase 3 trial looking at this particular question. So here's ACR 20, 50, and 70. So in all the arms, you can see is that that methotrexate monotherapy versus a combination therapy that that the combination didn't really make as big a difference. So monotherapy does work. So when you look back, you're like, well, why are we even thinking about methotrexate? It's really confusing because if you look back at the studies, there was a MIPA trial that started this whole sort of controversy, and that methotrexate was not very effective in psoriatic arthritis. So really, should we be using it with psoriatic arthritis? But then when you go and look at further studies, the TICOPA study, and then I have listed other studies here, DMARD, and other studies, RESPOND trial, it shows that methotrexate can sometimes help. So I think it's a little bit controversial what to do, but I think the SEAM trial was very helpful in looking at this. But each of you know your own patients better, and there's other reasons other than efficacy. There's also survival things that we talk about in terms of biologics. So IL-17, these are obviously a great new class. We have secukinumab and ixekizumab that's approved for psoriatic arthritis. I use this chart because it kind of reminds me that even though it's an IL-17 blocker and it actually has a lot of other various targets that can be useful. We now know that we have lots of outcomes measures looking at dactylitis, enthesitis, where this drug is doing really well, in addition to the skin and joints. The skin, as you know, I don't have all the data here, but we are reaching PASE 100 for these patients. This is complete clearing, and this is something that we haven't seen before. Unfortunately, I can't say the same thing for joints, but still it's a great drug to use for patients in psoriatic arthritis, so we have alternatives outside of anti-TNFs. Abatacept is also approved. I know you've seen some of these studies before looking that there is some benefit in joints and skin for psoriatic arthritis. We've also had a great talk with Dr. Strand on JAK inhibitors. So tofacitinib's approved, and shortly thereafter, there are many other JAK inhibitors that are also being tested with some good response in psoriatic arthritis. So those are in earlier phase trials, and we'll be seeing more of those as well. There are some also very new mechanisms that are out there that we don't really even know too much about. I thought this one was interesting. This is a nuclear receptor that's believed to drive further up both IL-17A, F, and 23, and these are small, they are developed as small molecule modulators that could be given orally, so that's why I thought they were interesting to mention. The other ones, I'm sorry, this is actually not the exact slide set, so I'm a little thrown off. But this is to highlight IL-23. So there's 2 subunits in IL-23. So I told you that overexpression is one of the most important things that we look at in the enthesitis. The 2 subunits are IL-23P19 and IL-12. And the reason that this is important, as you can see here, is there are drugs now specifically that are IL-23 blockers and drugs that are IL-12/23 blockers. So that's ustekinumab. And then the IL-23. So interestingly enough, the IL-23 is also very good in skin, has not done so well in joints, and it's unclear how they'll do. These are still early phases. They're approved for psoriasis. So as rheumatologists, we don't have as much experience, and as we'll await for some of the final trials looking at psoriatic arthritis. But for psoriasis, things like galselkamab, and I believe risankizumab or Skyrizi was, there was a lot of it during the AAD this couple months ago. So these are IL-23 specific blockades that are doing wonderful in psoriasis, and still more to come in terms of whether or not this is going to be used in psoriatic arthritis, and then it does not look like it's going through in the ankylosing spondylitis family of So the other one I wanted to mention is bispecific antibodies. So in addition to the IL-17 family that we're very comfortable using, or now that we know more of, there is now some new, instead of just blocking IL-17A, we have Bimekizumab, which is blocking IL-17A and F, with some very promising results in psoriatic arthritis. So this neutralizes not only the IL-17A but also F. It shows improvement in both skin as well as the joint symptoms, so this is something to look after. The safety profile in early stages seemed to be consistent with all the previous studies that we're used to, and it's in phase 3 development for psoriasis and psoriatic arthritis. So looking at general principles, so now that we've sort of did this sort of whirlwind looking at all the mechanisms that you've been sitting through for the past 2 days, how do we pick which drug is good for your patient? And I think we really lack a good biomarker where I would love to know the ones that are going to develop worse skin or the ones that are going to develop worse joints, the ones that are going to go into erosions. And so how do you sort of pick that first drug? So what we have available to us are treatment guidelines. So I'm going to go over one of the older ones, which is GRAPPA, which is a group for psoriasis and psoriatic arthritis research who came together looking at the GRAPPA treatment guidelines, which is one of the figures that I took from them. So these guidelines are really focusing on domains. So what that means is it really wants you to look at the patient and see where their dominant domain is and then follow an algorithm, as opposed to labeling them as psoriatic arthritis alone and going through an algorithm. So here you can see that the algorithms may be a little bit different if they have predominant peripheral arthritis, if they have enthesitis predominant, if they have skin predominant. So they sort of go in a domain like a treatment algorithm. Then the 2018 ACR NPF treatment algorithms, this is just newly published. What I thought was kind of unique about this was that it included patients on the voting panel for the treatment guidelines, so it's really nice to have patient input. It was really interesting being around the table and having patients there that are participating in the conversation for the treatment guidelines. I think the big news for this is one of the graphs taken from the publication, is that there is sort of evidence behind showing that after an active psoriatic arthritis patient and they don't do well on a treatment-naive psoriatic arthritis patient who's active, it actually recommends starting an anti-TNF earlier on. So this was something that I think was sort of a little bit of a different way that we may or may not be practicing, but these are some of the highlights of the treatment guidelines, where for psoriatic arthritis, you may be able to use a biologic earlier. We also have talked a lot about treat to target. So in rheumatoid arthritis, that's really been well known and has improved a lot of our patient outcomes. But in psoriatic arthritis, what do we know? Should we just borrow this over from RA and assume that all the same medicines we use are going to work and treat to target for psoriatic arthritis? And then what's your target in psoriatic arthritis? So if you're a rheumatologist, you probably tend to target more the joints, and maybe if you're a dermatologist, you might target more the skin. So when somebody has both, what kind of target are we looking at? What evidence do we have that treat to target also works for psoriatic arthritis? So here we have something called minimal disease activity. This is a way to understand where's our target, right? So in order to look at trials that look at targets, we have to have a target that we all agree on in this room when someone presents with skin and joint diseases. So here the MDA has 7 domains that it looks at, as you can see here. Total joint count less than 1, swollen joint count less than 1, and as you go down the list. And if you meet 5 out of 7 of these criteria or domains, then you're considered to be in minimal disease activity. So that's what they considered as their target. And this becomes important when you're trying to do a trial. So this is called the TICOPA trial, where they're randomizing patients into tight control. So tight control is, as the word sounds, is that treatment group. every 3 months, you're looking out for your patient, you're making a change if they don't meet minimal disease activity, or what they call usual care. So usual care is whenever you fit the patient in, however you do, you're just not using a metric, and you're not changing things every time you don't meet a metric. So tight control versus usual care. And what they've found is that the patients the patients that are in the tight control group are doing better than the patients that are in usual care. So there is some evidence that treating to target is going to improve patient outcomes. So this is one of our first studies looking at this treat to target in psoriatic arthritis, which looks promising. So many of you out there might be like, well, do I use MDA? Like, what if I don't use MDA? This, it's like, how do I remember MDA? So I think the important thing is that we try to have a metric that you're comfortable with in your office that you can use, and you use something. Just like in RA, there's so many different sort of target measures that we see. In psoriatic arthritis, there are also an evolving sort of conversation about which target that we should meet. But I think the most important thing is to at least have one that you're comfortable with so that you can use it on your patients, so that you can be better at trying to do the treat to target strategy. So as Mital has mentioned at the beginning, I'm really passionate about having sort of co-management care or rheumatology and dermatology collaboration. I think it does really help a patient. The patients really like knowing that you know who their dermatologist is or you know who their rheumatologist is. I think it creates just more conversation than just having, perhaps notes that you read back and forth. There is some value in picking up the phone. So even if you don't have easily accessible derm-rheum collaborations, I do see that we learn a lot beyond just reading a doctor's notes back and forth. I think there's opportunities for integrative teaching. There is, multiple ways that I've heard people do derm-rheum. Joe Marola is running something called Pac-Man, which is an innovative way of getting people across the U.S. to talk about derm-rheum collaborations. And Pac-Man has been really helpful in sharing sort of best practice strategies. So there's multiple different ways. People can do it virtually. People can do it all in the same room. But I think the important thing is that we feel comfortable talking amongst our different disciplines as well. So once again, I go back to my very first slide, just thinking about what are sort of the unmet needs and challenges that we have. So I just want to remind everyone that despite having all these new medications, these are really good for the skin. And we're really making a lot of big splashes. But in the joint world, it seems like, even some of the newer therapies are still getting the same ACR 20, 50, 70. And so what I'm hoping is that the next time I get up and talk to you guys that we'll have a drug that will be as good for the joints as it can be for the skin. Another area is really looking at your psoriasis patients and trying to find those that are going to have psoriatic arthritis, because the earlier we treat for psoriatic arthritis, the better their outcomes are as well. And then despite all these new therapies, I gave you a flavor of some of the treatment algorithms that are out there. They're not always something that you can just follow proscriptively. As you know, patients come in different flavors and they have different comorbidities, and you end up choosing different treatment based on that. So we're still a little ways of having a biomarker or something that we can know ahead of time. So here's just some of the key summaries that I talked about in terms of early diagnosis, treating a domain. So I think that's an important concept. We're really looking at a patient as a sort of maybe a domain-driven collaboration. Hopefully, this meeting has been really helpful as, you roam the hallways with people. It's interesting because I usually go to meetings where everybody's a rheumatologist and I don't really have to ask, oh, are you a gastroenterologist? Are you a dermatologist? But at this meeting, as you know, there's a lot of mix. So I think that's really great. So applying treat to target, educating patients, I think are all going to help. I think we are much more in an era where there's a lot more shared decision making than we used to having. And I think it's important with all of the biologics that you have a conversation that they feel that they're part of. I think it helps with adherence as well. So I think that is all that I have. So thank you. you want to take some questions, or you guys want to come up for the panel?
I think Elaine will be around, so feel free to, attack her as she leaves the podium here. Yeah.
Right. What will make you switch your patient to JAK inhibitor versus?
Oh, that's a great question. So I guess it depends if a patient has absolutely no response to previous to a TNF, let's say, or they have partial response. So that kind of weighs in. I think that oral is a very attractive, so patients that, I know I have some patients that travel a lot, and it's hard to keep things refrigerated. So I think there's a lot of different venues that kind of create that situation. I don't know if I can say that I would switch to a JAK inhibitor because I think it'll have a better joint coverage than, I just feel that people that are just not responding, I would look for a different mechanism of action. But I think that's where treatment algorithms are not as helpful as we want to, so it's more based on our clinical practice.
Thank you.
Thank you, guys.